set up. We have like a mock Crani set up here. And so I'm just going to go through kind of the rhythms and routines of what we do. So as you know, and we'll sort of think about it as an emergency case where we're coming up to OR for a stat Crani, and then I'll also speak to some of the nuances for like an elective tumor or something like that. So, so these are cases typically for the emergencies. As you know, time is brain, and we've got to get pressure off the brain to save neurologic function, and that's very time sensitive. The brain, unlike any other organ, we can't replace, right? So we very, very much, there's time sensitivity to kind of how quickly we can get pressure off the brain and recover that function. So, so these are folks that you'll see coming up emergently. We have our anesthesia folks work with us closely to get lines in quickly. And then usually these folks are already intubated from the trauma bay, and you know, Foley's need to be in place. Anesthesia will get IVs, and then usually the way to think about how we're gonna have the room set up and stuff is based on the side of the Crani. So for anything, you know, we think about the brain as supratentorial and infratentorial. So top of the head and back of the head. And so for the top of the head, which is most of these cases, right or left, right? And so that's going to be the side that we want up, okay? So in a right-sided Crani, we are, you guys help me out because I'm like, so we're going to be like this, right, on the bed. So the patient's going to be supine with the head turned like that. And so in general, all of our equipment setup is at the foot of the bed. So we're always going to turn kind of 90 if we're ever at the top of the head. We're at the back of the head, which happens, those are even more kind of time urgency cases because the brainstem, the most critical part of the brain that controls your heart and lungs and everything, is in the back. And so for those, usually we'll stay, you know, straight, and we'll just be prone for that. So we're going to think about, you know, sort of a right or left case. And so again, we're going to turn bed 90 degrees. Often we want a shoulder roll, and so that's really just, you know, 2 blankets rolled together, taped up, which we'll put under the shoulder typically, and then a little bit of differences in kind of what we're doing at the head sometimes. Sometimes we'll use a horseshoe. A lot of this equipment, perfect. A lot of this equipment is, and so this is basically a device that'll let the head basically sit on it, so that way we can work at the top of the head. Alternatively, we will sometimes pin the head in Mayfield pins. You guys have all seen these. So these get 3 pins, and then we decide kind of how we're going to do that based on, you know, where the problem is, right? And so all of our prone cases, all of those back of the head cases, are always going to use these kind of pins. So this is an important setup. I won't go through this too much, but these are attached to the bed with another connector, and you'll see us, you know, pin the patient, 80 pounds of pressure, about 60 to 80 pounds of pressure in the head. That will kind of keep the head stable. So when we're drilling and doing all of our work, the head's not moving. And occasionally, when we are using the Mayfield for an intradural or inside the brain case, we will also connect a stealth setup. And that will then allow us to be able to navigate where we're taking out a tumor, for example. So back to like sort of that emergency case. Okay, so we've got the head in pins or on the horseshoe. We're going to shave. We're going to prep that whole area. We're going to draw out our craniotomy. And as you guys know, for most of these cases, we are going to do sort of a big reverse question mark trauma crani, okay? And so that's a big amount of skin that we're cutting open. And the galea, which is the scalp, very, very bloody, you know, good blood supply. That's what allows us to kind of get great wound healing. And so because it's so bloody, we utilize, you got Randy's here somewhere?
Yeah, I think that's a cup right here.
Okay, perfect. So yeah, so we will sequentially, you know, we'll insert our, you know, 1% Lido with epi. Epi will help kind of decrease some of that bleeding. And then once we cut that galea, we'll use these Rainies and the Rainies allow us to basically tamponade. So we'll crack these open, shove them across the scalp like that, and then pop them. And we go, as you guys know, pretty quickly with that because the scalp bleeds a ton. We don't want to lose a lot of blood in just that initial portion of the case. So we're just going to go pop, 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 both on the top part of the skin and the bottom part of the skin and all around. And so once we do that, we will use periosteals. There's two main types, the Addison periosteals and the Langenbachs. I kind of like the Langenbachs, they're sharp, but you can use any of these. And that will then allow us to kind of elevate the scalp off the skull. Okay, so that will then allow us to kind of flap that scalp over. Sometimes we'll use kind of sharp towel clamps to then hold that scalp and pull it away. Other times we'll use 2-0 Vike pop-offs, some rubber bands, and hold it with an Alice. And that'll just kind of keep the scalp healthy, vascularized, and out of the way. Okay, so next we're down to the head, right? The whole point of being in there is we got to get that pressure out of the head. So that involves obviously drilling the skull. So Melissa, you might need to help me out here. So usually what we will start with is the perforator. And so that bit is going to allow us to sort of create, you know, something like 3 to 4, you know, burr holes on the head. So we will have this all set up, and then, you know, we're going to go sequentially across that and drill our multiple holes, and then we'll use the curette, which is on your set, to kind of take away, there's always a little bit of bone chip sitting in the area that we drill, so we'll peel that away. And then sequentially, you know, in all of us, our scalp and what's called the dura, which is the covering of the brain, are very, very close together. They're very tight in healthy brains, especially so in people who have big bleeds in their head. So we will use elevators to kind of separate the skull from that dura. And this is a Fraser right angle, so we'll typically use something like this. We'll also use the Penfield 3. Penfield 3 has like that nice curve to it. So we'll kind of work through the burr holes that we made to kind of do all of that dissection. While we're doing that, it's helpful for you to take that drill back and then put on this next drill bit, which is the B1 with the foot plate. And what this allows is, after we've done that dissection, we are then able to, again, you know, since we've already dissected the skull from that inner layer, now you can actually put this foot plate into that space, and then we will turn our craniotomy flap. Everyone who does this knows this. Everyone's holding that cranie. You certainly don't need craniotomy falling on the floor. So, so we'll kind of hold that in place and drill that all around, and then we will typically take it off. So usually we're going back to that Penfield 3, which has that nice curve. Sometimes these smaller Addison periosteals allow us to kind of really then lift up that bone flap off of then the dura, which is that next layer. Okay, so that bone, by the way, goes nice and safely into one of these things so that it does not get, you know, lost. Sometimes we'll put it back, sometimes we won't. The surgeon will decide that based on how full the brain is. So at this point now is sort of mentally, okay, we are now going to get into the dura, right? We think about these steps of the case as kind of separate. Those first parts, we're doing lots of big stuff very quickly. After we're going to open the dura, the brain, especially when it's under pressure, is going to want to herniate and fall out of the head. We don't want that, right? So at this point, you'll hear us usually talk to anesthesia, make sure that we get the intracranial pressures down. And so the things to do at this stage are think about, okay, what's going to happen intradurally? So when we're intradural, typically now we're going to use kind of, generally speaking, finer equipment and things like that. All sort of depends on the indication for the case. So for example, if it's a big subdural hematoma, that means there's going to be a big blood clot squashing the brain underneath that dura. So we are going to quickly want to take that out. So usually, and I didn't mention this earlier, our workhorse suckers are these 12 French suctions. Usually we'll stick with that if we're doing a big subdural. If we're doing a tumor inside the head, we're gonna go to finer things. For example, your 8 French suctions are in here. That's typically what we switch over to once we're going intradural. And so the dura is that covering. We still have to open that, okay? And the way in which we're gonna open that is typically, neurosurgeons love bipolars. These are bipolars. Think of it as like an extension of your finger. So this little bend is always on the top when you're handing it. And usually we're just kind of using it like a pencil. So you're just gonna hand it, and this is sort of pinch and bipole, okay? And there's different, this one's a nice insulated one, the blue part's insulated. These only work at the tips, okay? So you'll hear us say, can you clean the tips for us, please? And that's because if they're, what'll happen is, as we coagulate, there'll be char that builds up in between the tips, and then it doesn't work. So those are important, and usually we have a couple of them on the set, so I tend to just kind of swap out while we kind of clean those tips, because that allows us to keep that going. And then the other things that we will use are Cushing forceps. These are really fine forceps that have teeth at the end. This allows us to pick up that dura. The dura is actually a pretty fibrous structure, and so we actually can lift it and pick it up with these. Usually at this time we'll also go to our 11 blade to open that dura, nice and sharp and pointy, allows us to very discreetly open that up. And then at this point we'll also, we all call these fluoroneuralons, but they're not, I don't know what the heck they're called, Surgilon, nylon, whatever. This is the thing, okay? I think they live outside of 16, right? So fluoroneuralons, if you hear us say that, we're talking about these things, okay? And those very fine suture. So again, once we're going intradural, everything gets converted to like all of these stuff. So these get loaded, and what happens is we will use that 11 blade to open up the dura. We'll use our Cushing's pickups to kind of lift up those edges. We will then sew the edge of the dura with these fluoroneuralons, and then I like to just sew it right onto Gallia. Other people will use like mosquitoes to kind of hold the suture that we've then sort of created to kind of open up that space, right? And so at this point now we have, either the brain exposed or the big blood clot that we're there to sort of decompress. So if it is a subdural hematoma at this point, we are going to use tons of irrigation. These are the big bulb irrigations. We typically will go through a ton of these, as you guys know, and we're going to irrigate and suction with those 12 French or the 8 French, and do our dissection. Sometimes at this point, if we need to take tumor or blood or whatever off of critical structures, we're going to use things like the Penfield 1. Penfield 1 has a nice little cup at the tip on one side, and the other side actually looks like a Penfield 3 but doesn't have as much of a angle there. And this kind of helps us kind of dissect off the brain, etc. So this instrument's a workhorse inside the dura. Another instrument that we'll use is a Pen 4 sometimes to kind of similarly do that dissection. Those are kind of like the big ones for big stuff. And so that's kind of, in general, for a subdural hematoma, those are kind of the steps. And so we'll kind of, again, until we get that pressure off the head, it's like time is ticking for that person's brain, right? So we are usually moving pretty expeditiously through all of that part. Now, I'll go back to intracranial in just a second, but to finish up a subdural case, after we irrigate all of that, get a nice clean space, sometimes you'll hear us ask for ventriculostomy. The ventriculostomy is basically a tube. There's good level 1 evidence that tells us that if we leave a drain, basically just like we do in other parts of the body like the spine, it'll help keep some of that fluid off the head. So we'll insert a ventriculostomy on top of the brain to kind of suck away any of that blood. And then sometimes we will put that bone flap back. If we do put that bone, I don't think we have a set here, but it's okay. What we do is we'll put that cranial flap back on on using tiny plates and screws, as you guys see, and we just go back and forth with screws and put that back on. We will sometimes close that dura again with the 4-row Neuralon, and sometimes we'll put a large piece of Duragen on there, so you'll hear us ask for that. And then we close up the Gallia. So the Gallia usually again with 2-0 pop-offs. We love pop-offs. Yeah, so those look like these ones, right? Okay, so these, okay, we use a ton of these pops and just sort of close up that whole scalp, and sometimes we'll leave a drain in there too, and then usually staples for the skin. So that's like a subdural hematoma case. Back to the head when we've opened, if let's say it's a tumor inside the brain, at this point, I'm going to backtrack for a second because now I'm seeing all this stuff here and I'm like, oh, whoops, I forgot to go through that. Before we depending on where we need to take off the bone flap, there's a lot of good vascularity. We already talked about the vascularity of the scalp. That's why we use Rainey's to kind of stop that bleeding. At the skull, the bone bleeds too, right? And so for the bone bleeding, we're going to use these balls of bone wax, and we'll all do it a little bit differently, sometimes on the back of a Penfield 4 or Freer, sometimes right to our hand, and we'll put it down. And then the other thing that bleeds is the actual dura. And the dura has very important blood supply called the dural sinuses. That is what all of your cardiac output is leaving the brain from. So people will die in 5 minutes if you don't control that. So that is like mission critical. So you'll hear us say, we're over the sinus, we gotta have like blood stuff in, ready to go. And what that means is there are these pieces of gel foam that we have you guys cut up. We call them gel foam worms. And basically what this allows us to do is sort of close off the area that we pop the cranium from, the bone, and the dura, and it sort of seals that whole area off. Sometimes if we're right over the sinus, then we need big pieces, like pieces that kind of look like this size. Okay, so you'll hear us say we're right over the sinus, big sinus gel foam pieces, okay? So that's what that means, and then we do, we use Flow Seal, we use gel foam, we'll use these patties to kind of really block off that blood. Again, that blood, you will die on the table if that bleeding kind of persists, okay? So that's where we kind of get all that nice hemostasis. And then, again, then back to opening up the dura. So once dura is open, if we are doing an cranial tumor, abscess, whatever, at this point now we're going to need to go inside the brain. So often we're using things like the self-navigation, which has a blue wand, you'll hear us ask for. And that allows us to sort of localize where we want to go. And so the first steps there are going to be that we need to do what's called a corticectomy, okay? Corticectomy means we're going through the brain, okay? And so, thank you. Okay, so this is the blue wand. It has these little balls on it. Those balls have to be clean because the only way for the camera to see it is if there's no blood and stuff on it. So sometimes you'll see us kind of like mess with that. And so this thing we usually leave on the Mayo. We try to leave it like protected and all that. But we'll decide, okay, we've got to get to, this particular part of the brain. We're going to be navigating that. So once we're happy with that, then we're going to do what's called a corticectomy. And corticectomy includes using the bipolar to coagulate that surface of the brain. And then at this point, you'll want to have all your rodents set out. This is all of our micro instruments that we use inside the brain. And so in addition to this, we'll utilize the micro scissor, which there's usually a curved and a straight one. And so once we do that corticectomy where we're sort of coagulating the surface of the brain, we will cut a small opening in that surface, and then you'll see us again go back to, we always have two things in our hands, either the 8 French suckers or these are the vascular suckers. So we'll tell you kind of what we're looking for. Usually it's like a 7L, 5L, whatever. these are a little different because you can see from the Frasers in that we're able to kind of suck a little bit and suck a lot. So unlike the Fraser where you're either on or off, here you can sort of dictate how much you're providing suction. But either way, so we've got, our suction and we're bipolaring. And now at this point, you'll see sometimes we'll use that Penfield 2, Penfield 1, Penfield 3 to sort of open up that space that we need to get into. And then, at this point is where you'll want, these, you probably just should get familiar with them at some point. These micro instruments are all Rotens and they have numbers to them. This is a Roten 4, it's very wide. It actually looks like a Penfield 4, but it's like the mini version of it. 6, 7, and 8, and 4 are kind of all the dissecting looking things, okay? And they might not seem different, but they are. They're different in their kind of like width at the tip of it. So we'll tell you guys kind of what we're using there. And then there's other instruments in here, including a round knife, which looks like a little circle at the tip. So usually, at this point, before we're going into the head, we kind of set up the Mayo with the Roten instrument so we can just plug and play in terms of which one we're going to use. And so now's where all that micro dissection happens. A lot of the times we will use the microscope at this point too. And then we are basically dissecting and taking out, for example, tumor. These are the tumor graspers on the Crani set. There's a really small one, there's a medium one, and then we call this Big Bertha. I don't know what it's actually called, but whatever. Just depending on, the size of what our lesion is, these are the tumor graspers that we'll use. Sometimes we'll actually also use, there's a micro pituitary on this set here, and a micro tumor grasper on this set. And so sometimes we'll use these guys also. So a lot of that tedious work is done under a microscope, as you guys all see us do. Sometimes we will utilize the irrigating bipolar. The nice part of the irrigating bipolar, unlike these guys, is like I said, remember, all that char builds up on these, whereas the irrigating bipolar, because it's irrigating, you get that's all right. You get less of that. So it's sort of, so this thing gets connected to water, right, to saline through that bulb, and it comes out through this little hole here. So when we use it, it irrigates automatically, so you get a little less char. There's no perfect, but we'll use one or the other of these. But the idea is still the same. We're coagulating, then usually micros is, and then we're resecting. And again, we'll tell you kind of what we're sending off. It's pretty important to make sure that everyone's on the same page of that. Usually for a lot of these cases, we are sending frozen. We're sending permanent, etc. So that's all kind of separate. And then, again, once we're inside the head, bleeding is always something. We don't want bleeding inside the head, so we're doing things like, okay, tiny pieces of gel foam. This is already small, but guess what? We do that in basically quarters for when we're inside the brain, okay? So we'll sort of do that. We'll do flow seal occasionally, and I don't even know if you guys have them here, but we'll sometimes use cotton balls, which have springs to them. Okay, perfect. Yeah. So if we're doing like a big cavity, those cotton balls are helpful. And all these things are have radio opaque lines. So we count all this stuff. We make sure everything comes out of the head, et cetera, et cetera. So having that set up is really critical. Once we do all of that, we'll irrigate out the cavity, and then Melissa's kindly done a nice job here of setting up our Surgicel. Okay, Surgicel, we will use that typically to line the cavity of whatever we took out, right? So these are good hemostatic agents, and so we use a variety of these kind of just different sizes, shapes, whatever. It doesn't have to be perfect, but what we're basically then doing is using, and we love neurosurgeons, as you can see, most of our instruments are bayoneted like this. So, right, so we will use, our regular bayonet to kind of take the Surgicel, line it into our cavity, etc. So that's kind of what we'll do there. And then similarly, we will, put bone flap back on, plates, screws, all that stuff, and And yeah, I mean, that's, what, am I missing anything, guys? Lucy? Yeah, that's, I mean, those are kind of the big, main things. I'm just looking at what other instruments you have here. Sometimes, you know, when we have to take off parts of the, well, yeah, the little lemper here, these are tiny rongeurs. You guys see us use the big guys in spine, but sometimes at the head we'll need to take off small amounts of bone, in which case we'll use one of these. These are called Cushings. We like these because especially when we're putting in burr holes near where the scalp is, we don't want the scalp to get caught up in the drill. And so you'll see us use this to kind of pull that away. Brain malleables, if we're in a part of the brain that we need is deep, etc., you'll see us kind of use these, bend these. Often we're, you know, using a patty with it to kind of protect that brain, okay? And then just real quick, when we're at the back of the head, a little bit different. Same conceptually, right? We need to get pressure off that brain, but in this case, we're prone. And so again, we always will use the Mayfield, and you'll see us put this on while the patient is still supine on the bed, clamp at their head, and then as you see, we'll flip onto typically a regular OR bed with chest and hip bolsters, and then we'll connect the head to the head of the bed there. And then, you know, again, similar conceptually, we're now opening the skin, and in this case, it's the back of the head, which has a lot more muscle, right, compared to the top of your head. So there we're using kind of a little bit more kind of spine-like stuff, bovies, blah, blah, blah. And then we love these cerebellars. You see us use this in the spine a lot. This was called a cerebellar because it has that same shape of the way the head is shaped there. And so you'll see us kind of use that. Sometimes we'll also use the Rainies, but these actually work pretty well to kind of separate that scalp tissue. And then same sequence. We're gonna wanna drill burr holes across that back of the head to take off the skull there. Often when we're doing a post fossa, we call it the posterior fossa craniectomy, it's a craniectomy because we're typically not putting the bone back, as opposed to a craniotomy where we are putting that bone back. So typically for a post fossa, we're taking bone off and we're leaving it off because that part of the brain doesn't have a lot of space, and usually we leave that off. And then sometimes you'll hear us ask you for that B1 without the foot plate. What that is basically this thing comes off. Melissa, you wanna? I don't remember which thing it goes on, but basically that L shape goes away, and then it's just that drill tip. And that drill tip allows us sometimes to kind of drill the skull bone, right? And basically just make a hole in the skull bone. And then you'll see us use foroneurons, and what we're doing is connecting. Remember I said the skull and that dura are very closely adherent, but when we do the case, we're separating that, right? So when we want to put that back together, we're sewing with a foroneuron back to those little holes to kind of put that all kind of back together. So that's the B1 without the foot plate.
Yellow.
Yes.
Yellow. Some of the equipment that you use in the pictures and how.
Sure, yeah. So, I use this drill. This is the electric Midas. You guys are probably used to this a little bit more, but it's all kind of the same a little bit in that, you know, this is like the workhorse drill that we use, as you guys know, both in the head as well as the spine for the most part. So the most common things that we're going to use are, again, that perforator, the B1 with the foot plate, B1 without the foot plate. Occasionally we will ask for the M8 or AM8. M8 is the shorter one. AM8 is the longer one. AM8 you guys are used to from spine. We use that all the time in spine. But the M8, sometimes when we're at the head in kind of these smaller areas, yeah, they're not, of course, they've changed all the names to everything, so I don't know. But anyways, so yeah, AM8 and M8, and you know, the color of this thing matches, you know, what kind of cover you want to use it with, okay? So, so that's those drills. This is the sonopet, right? Okay,
Megan,
so the sonoped,
Sorry.
and again, Lucy or someone else is gonna be able to tell you more about that. I will tell you, the sonoped, nice instrument for us, in that what it allows us to do is with a single instrument, it kind of like looks like a little bit like a drill, but what we're doing is both suctioning tissue, thank you. It looks like this, okay, and so what we're doing is basically sucking away tissue. In most cases it's tumor, and we are collecting that tumor when we're in sort of critical areas. And it also has the ability to irrigate, which is nice. So all the same kind of reasons, right? Anytime you're messing with the brain, it'll coagulate, tissues will tear. You don't want that in the head, right? So irrigation and suction all in kind of one, and that allows us to carefully take out tumor. Bipolar, again, every case pretty much is set up with a bipolar. That's, you know, workhorse for us, you know, in all of our cases. The Malice is the one with the irrigator. So the greens are called Kerwins. This is the one that has to work with this. If we're doing a regular bipolar, that's these things that are always part of any tray. So that gets connected to your regular, right? And tell me if I'm wrong, guys, because I don't know.
The regular.
So that goes to the regular Bovie setup and all that. But if we're doing irrigating, which often we are when we're inside the brain or inside the spinal cord, then this whole setup. This is the, you know, foot pedal for the big drill. This one has its own foot plate, which is this one. I'm looking around the room here. All of that you guys are familiar with. And the scope, something important to ask us before it's getting balanced and everything is, are we using an observer, which side? So you can imagine if we are inside the head for a tumor, we're going to be looking down inside the head. We're going to want our observer on the side of us. They can't be across of us because the patient's body is over there, right? So that's a little bit different than other uses of the microscope. So often we have to move the little eyepiece and put it onto the side and then balance it, okay? The stealth is another kind of important, you know, equipment that you guys are used to on the spine side. We use it pretty similarly in the head. Really that, the blue wand, what do I do with that? Yeah, this thing, and sometimes we will navigate other instruments with it, and what that means is we put a similar tracker to the balls that are on this thing to another instrument, and that then allows us to use the other instrument to navigate kind of what we're trying to take out. So that's a whirlwind of craniotomy. Happy to answer questions, or if anyone